Thank you for joining us for the December edition of Coffee with Coker. As always, it's a privilege to have you join us. Immediately following today's presentation, we'll have a question and answer period, so feel free to submit your questions in the area provided in the GoToMeeting dashboard. The participant phone line will be muted for today's presentation, and the materials will be emailed to you shortly after the conclusion of the session. As you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation as well as suggestions for future topics. Sandy Champion is a Vice President in Coker Group's Hospital Operations Division and a respected healthcare consultant executive with over 20 years of experience designing and implementing community needs assessments and the medical staff development plans. Founder of Champion Healthcare Consulting Group, Sandy recently joined Coker Group to bring our clients the most realistic and comprehensive analysis through a unique product known as the Demand Tool. Please join me in welcoming Sandy.
Hello all, this is Sandy Champion. I want to thank you for joining us today, and I appreciate the opportunity to work with you, and many of you I already have, and I'm looking forward to looking at the future. So what I'd like to cover today is some industry changes and their effect on physician workforce planning. This is a field that has changed tremendously, both for hospitals and medical groups as they go forward to try to understand their service area. We want to look at the fundamentals of community need analysis, or CNA, which is really just another word for physician workforce analysis. We want to look at the required federal recommendations for documenting community need when hospitals are recruiting physicians to their defined service area. And we want to look at how to structure a comprehensive physician inventory or listing. In this case, I call it a database, and how to apply the CNA tools to a medical staff development plan. It's kind of different from a medical staff plan. So today's agenda, what I'm going to go over really are just some three basic areas, which demonstrating community need through analysis and planning, and what is a CNA, who needs to do a CNA, identify the fundamentals of the CNA, and key pieces for the MSDP, applying the CNA tools to an MSDP, or medical staff development plan. And then we'll have an opportunity for a question and answer period. So be sure to include your questions, and we'll be glad to get to those when we get to the end of the presentation. Some time ago, I had an opportunity to work with a community hospital that had an employed physician who felt that the hospital and the medical group which she had joined did some unfair recruiting practices. And that became a huge lawsuit where everyone was named for their part in that recruiting process. Because the hospital had 8 years of documentation clearly going along sequentially and showing that there was a need for recruiting in that particular specialty at those particular intervals, the case was thrown out. And so I've had real experience around what that documentation needs to look like, and hopefully we'll be able to demonstrate that for you today. So I guess the main point really is, from the community point of view today, we have to look at physician workforce from the community view, what the community expectations are, their population risk needs, their hospital and medical groups in the area in terms of their responsibility to serve the right access and also the right number and type of physicians to be able to do that. So think for a minute from the community's point of view rather than from your practice or your hospital point of view. And of course that leads directly to the Stark regulation. So for sure, medical staff planning is not as simple as it used to be. When I first started out, it was a luxury. We didn't really do them very often, but it was that physician component of the strategic plan for the hospital. But today it's become much more in-depth and comprehensive, and it has to really be proactive and really intuitive for your particular institution. So the reasons for that is that really there's a lot of uncertainty around reform, of course. a lot of movement around clinical integration, employing physicians for hospitals. They're certainly getting their skills now to recruit primary care, those hard-to-recruit specialists, and also to cover call. Those are the three big buckets where you see hospital employment. And highly competitive marketplace. You know, the more competitive the marketplace, the more contiguous it's going to be. So the fewer candidates, the shortage that's been predicted and continues to be a competitive recruiting opportunity is really because of the shortage. It's very, very difficult today. My respect goes out to those of you who do the recruiting piece of it because it is also equally highly competitive. The fewer resources and, of course, the reduced reimbursement is going to continue, and so decreasing community access. From shore to shore, I see decreasing community access from a community point of view, new residents in a community trying to find a doctor or a timely appointment. And we've done lots of studies around, you know, what those expectations are. Newly covered lives, of course, and certainly the baby boomers joining that group, and continued emphasis on quality, clinical outcomes, and population health improvement. That scenario, and so engaging the community in defining what those measures are going to be, and the evidence is going to continue to be important in the planning process. Also, aging out of physicians. We know that a good portion of them that are in practice are over the age of 55. We know that the age at risk for retirement, which we don't say you're going to retire, we say at risk for retirement or replacement, is typically around 60 to reduce their hours. 65 probably is the age from which you should be planning. Younger physicians typically are less productive. They ramp up their practices. And certainly then nationally, greater use of primary care mid-levels is one that we see growing. Certainly all practices, a statistic of almost 12%. And multi-specialty groups are really looking at 23% of their staff are mid-level primary care providers. The provider gender productivity is really interesting. There's a difference, and many of you already know this, between males and females in terms of encounters that they see a week, office visits, and the average hours they want to spend in the office. So there's also a divide between, a gender divide between their expectations for quality of life and part-time providing. And of course, private providers, there's a declining role of private providers, and more are either in group or hospital-employed practices now. So what's the challenge? The challenge is to recruit, to meet the compliance guidelines, and therefore to plan to match the future landscape while focused on quality and, of course, retention. And we'll talk a little bit about how important that retention piece is in the planning process. So what is a CNA? Community Needs Analysis, obviously. It is for really physician workforce needs analysis is another way to say it. You want to be able to develop really proactively. That means in advance of recruiting. Multi-year, we recommend 3 to 5 years, multi-year community need analysis and medical staff development plan, those two pieces, with conclusions for recruitment, compliance, certainly if you're a hospital, strategic capacity building for the hospital service, in other words, growth. So what does it look like today, and what do we expect it to look like, and therefore be able to translate that to the numbers of FTEs and specialties that you're going to need going forward. The definition is really a CNA is an analysis of the medical providers within a given market or service area to determine the need for additional providers in the future, typically, as I said, 3 to 5 years out. As you know, that information gets old very quickly, so we typically like to look at 3 years out rather than 5 years out. Hospitals are required to document the community need. And this is from the hospital perspective before they can provide financial assistance or recruiting activities to a private practice physician. And that financial arrangement between a hospital and an excluded party doctor is where the scrutiny comes in, where the Stark regulation covers that, which is managed both by the IRS and the OIG. But it also works for when you're employing physicians from the planning perspective to understand your workforce analysis. So there's really two reasons, compelling reasons I call them, to complete a community need physician supply analysis and plan. The first one is the compliance. If you're a hospital, you may provide remuneration to recruit and to relocate to your hospital's geographic service area. And that service area is defined for us by the Stark regulation that says it's that area that is comprised of the lowest number of contiguous zip codes from which the hospital draws at least 75% of its patients. Or if you're in a rural area, you're allowed 90% of those zip codes, contiguous zip codes. In which case, then, you must clearly document thought process around these bullets. One of them is that there aren't enough. So you have to be able to understand how many you have, to what degree they're available to see patients, and that going forward 3 to 5 years out, there aren't enough in the community based on population demand ratios, both the affiliated and the non-affiliated in your community. So it's not just your medical staff or those practicing physicians in your medical group, but to document current and forecasted need, again, 3 years out, for that, again, defined service area. We'll talk a little bit more about how you can stretch the service area. Demonstrate inadequate access. This is a big piece of it, because if you have so many FTEs that are in your market, but 30%, 40% of them no longer accept new Medicare, Medicaid patients, then you're really, you're recruiting, you're not really growing, you're simply just replacing those that are unavailable to see patients. Demonstrate loss of community program, and demonstrate the risk of loss of physicians due to departures or risk of retirement. And that's kind of complicated in your documentation. I'm more than happy to answer any questions for you regarding that. The other reason to do physician community needs, physician supply analysis is really for labor management, to understand who's in your community. And if you're recruiting even a medical group or you're employing a physician, it's good to have this documentation, because before employment, you're actually in a recruitment mode, and there's more scrutiny in a letter of understanding at the OIG level that says, you know, that those are recruiting activities where you have a financial arrangement. So it's good to have that documentation even when you're employing physicians or a hospital is employing physicians. From a medical group, again, it's also important if you're recruiting or bringing on a new partner to know that in the community there's actually room for that new physician, rather than sort of slicing up the pie in terms of cases, to be able to say that that physician can be successful in the community. From the compliance point of view, you know, really the language is here for you to look at, but the two big points are that you have documented evidence going forward that there is room, a community need for that recruited physician to be attracted to the area, zip code area of your service area, and that evidence should be compiled by an objective party. So obviously what they don't want is that, you know, you write your own documentation, that you at least every so often have an objective party look at the evidence of community need. Documentation of the Stark service area defines a hospital's geographic service area, as we said. The contiguous zip code map also is part of a CNA. It's typically included in every CNA, so that we draw that map and we say, okay, here's the 75th and here's the 90th, and do they touch each other? That's a complicated, sometimes it can be complicated, especially where there's water or there is a planning service area that is beyond the contiguous map. But that is part of the requirement. Also, we look at demographic, population, market analysis, access to care assessment as well. Those are all pieces of a CNA process or assessment. And determination of the current FTE workforce. So that includes what we would call a full-time and or what that percentage of full-time is. And for primary care, we do include and we want to include mid-levels in primary care, usually family practice, internal medicine, peds, also OB, women's health, and probably psych mid-levels that are seeing the bulk of patients. And we count those mid-levels at 50% of their full-timeness, which is a new word, but what it does is it sort of follows the national primary care study to say, you know, what is the scope of practice and how should we be counting primary care mid-levels. If we counted them in the other subspecialties, medical and surgical subspecialties, you know, we would really be overstating. Although I do expect in the next 5 to 10 years that that will change as more mid-levels in the subspecialties take on a greater role. Physician input is essential, and we provide that certainly in a CNA process as well. This needs to be physician-led, needs to be physician-validated. Do we have the right people? You know, the attrition or succession is another, I guess, compartment of the CNA as well. So of the workforce that you have, how many of them at the FTE level are expected to be at risk for retirement by the forecasted date? And then the specific objective recommendations. And really those recommendations, you'll see example of that, become really your CNA analysis plan by specialty for that 3-year period. So how do you do a CNA? Well, quantitatively and qualitatively is really the two pieces. Certainly quantitatively is just that statistical piece. We look at the scope and the methodology, the service area, we understand the demographics and the population and the contiguous zip code map, all of those pieces, as well as setting up this comprehensive database, which obviously it's an Excel listing of all the area physicians and the primary care mid-levels by FTE, by planning area, and we'll talk about those planning areas. The statistical comparison then, or the demand for the need to benchmark against national workforce populations. And while those ratios, we all know, started with Giminick, and of course they are all across the board, many of them are suited for certain types of markets, and we can talk about ratio definitions and how we recommend to do them. So that comparison then becomes that number, that future number that says this is how many you have as a shortage or that you're stable going forward 3 years out. Overlay on the statistical analysis is really those market factors, and that includes all of that physician practice intelligence that has to do with access or lack of access, barriers to care, those market-driven conditions that would affect how the community is able to get an appointment. Wait time over 3 weeks, certainly whether they accept new patients or they're closed full, if they're limited because of screening practices, or they don't take back pain patients or multiple medical problem patients, those kinds of screening activities as well has to do with the market factors laid over on top of the statistical analysis to be able to say, you know, what you need. And then consider recruitment activity and barriers as well. If you're an institution that has been recruiting and you're not able to attract anyone to your community, you may want to relook at the statistical analysis to say, well, you know, we're having difficulty in attracting and signing physicians into our area, so that becomes therefore a barrier. And it's, again, documentation to be able to say how we want to move forward. And then the final step is really to adjust the estimated current and growth market shares. So the statistical analysis, the quantitative analysis, is really assuming 100% market share. So if everybody in those zip codes that you've defined as your 75th, your 90th, and your primary service area, if everybody only came to those, to your hospital, you know, what would the need be? But in a competitive market, of course, there are others that are as well attempting to attract physicians outside of those defined service areas that may be yours. So we like to go the next step and look at the current market share and then adjust that number. Now that doesn't give you any net growth, but what it does is it says, you know, just to maintain where we are in terms of service, how many would we need? So if the 100% market share was that you need 10 family practitioners, but the market share was 50%, you'd really only need 5 just to maintain your market share. And then we like to be able to go a third step, which is to say, well, what if we wanted to go to 55% market share or 60% market share? Then what would we need to do on the physician supply side? And finally, the last step is really those objective party recommendations and a demand analysis tool and a final report, which really today needs to be very easy to read, very usable. You know, if you could put it on your iPhone, that would probably be a good idea. Many of the older static 300-page reports, you know, really are not what folks need today to move forward. So the typical specialties that we look at are in these categories of primary medical and surgical specialties, but these are just the typical ones. We can also certainly go look at orthopedic subspecialties. We can look at pediatric subspecialties. We can certainly break those splitters apart as well, and that way, you know, all of those specialties can be covered. But these are just basically the general ones. Finally, the recommendations. This again is what I said. This is your objective party recommendations going forward, and it also becomes sort of the driving plan. So if you look at the first column, again, it's primary medical and surgical, and you can see that in the first column, 100% market share by 2020. You know, the red numbers are significant in that there's a deficit. And then we market share adjust that, and then what does that really mean? And then additional succession that we would need by 2020 or 2018 in this case. And so what is the total needed? The last few boxes really are the objective party recommendations based on the qualitative analysis overlaid, as well as, you know, how long it takes to ramp up a practice and so forth within a short 3 to 5 year window. So that's really becomes your plan, and whether it's critical, high need, moderate, low need. And then it's divided by how many new and how many replacement with a total. So that really is the CNA process, which then becomes an input document, as you can see, for the analysis findings become input for the MSDP, which is the next step, or the strategic roadmap. This is your plan. So you can step away from the compliance now, and you can think strategically for the physician component of your hospital or medical group's institution strategic plan. So you take the CNA analysis and your findings, and then this will ensure that the organization has that right number and type of physicians to serve the community. That's in the CNA piece. But the MSDP is really a strategic plan. It includes the analysis of your competitive market. So here's where that competition piece can come in, and what strategies and market position you want. It formalizes, and really that has to do with doing this in advance. Physician development. Physician development is very different from a medical staff plan or a recruiting plan. It really goes deeper to look at recruitment, replacement, retention, and how to redirect physicians that are already in your community. It also looks at those strategies and actions and return on investment for recruitment and or what you're not getting by not recruiting. It provides regulatory and tactical support for hospital supported physician recruitment as well, more documentation, and it engages physicians in the planning process. It's very important because it really should be physician driven as well, or certainly physician validated. I usually do this with a good crackerjack team of physicians that like to this kind of work, and it's not in the format of a restraint of trade, but in fact it's helping define what the future looks like over that scope of years to be able to formalize those goals, priorities, strategies, tactics, timelines, budgets, and the return on investment for each recruit that you plan on growing, you know, over the next 3 to 5 years. And then the various alignment and considerations and options are also beyond the competitive market strategy, you can also now look at those alignment and considerations that you and affiliations and the options that you want to do going forward. So this is really a strategic plan, a well-developed, in advance, intuitive strategic plan around physician development, which includes multiple pieces. A typical MSDP would be, here's a table of contents. And the interesting story, if you look at strategy 1, retain current medical staff. This came about at a hospital where we did the MSDP, and we first of all, we had replaced critical deficits, and then we said recruit primary care, recruit medical specialists, recruit specialists, surgical specialists. And the physician leadership group that we worked with were just really fantastic, and they said, no, you need to have retention as the number one, because before you go out to recruit, you really should have those strategies and priorities and goals and tactics in place to retain the current staff that you have. So it sort of turned upside down after that in terms of thinking. So strategy number 1 is really to retain your current medical staff, and what are those priorities and strategies that you're going to do in terms of communications and involvement and so forth in retention activities. And then the second one, very important, of course, is to be able to replace critical deficits, the critical deficits due to current exiting physicians. And then you see the traditional strategies around recruiting for primary medical and surgical specialists. And then also you'll see those for succession. Strategy 6 addresses recruit replacement providers, develop and maintain a succession plan. And that's sort of in a separate bucket, but it also needs to be certainly very active. What you don't want to have happen is that those physicians start to slow down and or resign without having the opportunity to mentor the new physician to come in and maintain those records. And strategy 7 is really to recruit new hospital-based specialists. And that's usually contracted. It's not really population-based, although we can do that. It's usually workload and caseload. But certainly it needs to be part of a medical staff development plan. Number 8, strategy 8 is really interesting. This is where you actually highlight and define every step in a recruitment process, including those compensation models that you're willing as an institution to limits, if you will, what you want to pay, what is that range, what are those profiles within those ranges. And strategy 9 is redirecting area physicians, if that is a strategy, but it is part of a physician development plan. So if there are physicians, even visiting physicians from other areas, to come in and serve those specialties, especially in the rural communities where you may have a specialist come, a couple of times a month, even for half day and in the afternoon do procedures. That's what this strategy is about. And strategy 10 is really to focus on physician communications. And this is, in the old days, we called it physician sales or physician communications, which is, what are the rules of the road? How often and who is available to continually stay in contact with those physicians that are aligned and or perhaps not aligned, but they're community physicians, and so that, there's constant opportunity for them to participate in the hospital or the medical group's planning process. Strategy 11 is really to implement an ongoing physician retention plan. So if the retain current medical staff is number 1, number 11 is the ongoing retention plan. And then the other big pieces are then you pull all this together into a well-developed, comprehensive action plan that addresses the cost and the return on investment or the value of that recruit, and the timeline, of course, who's available as well to manage that process. So this is really how you lay out a medical staff development plan, again, starting with the CNA as the input or the intelligence around then how you would make those strategic decisions. So my final thoughts really are interesting. Someone gave me this on a card once. A physician said that all retention starts with recruitment, and that all recruitment starts with planning. And all planning begins with analysis, and all success is planned. The next steps beyond the CNA and the medical staff development plan are really to determine your overall scope for the analysis and assess your internal and your external influences. This is a really important step. In other words, it's sort of like the old SWOT analysis, but to look at internally where do you have strengths, and that would include your physician leadership, your I guess your administrative leadership, but it also looks at your budget. It looks at your process as compared to a competitive process around, who is attracting physicians and retaining physicians, what kinds of tactics are they actually using that are working, and to know what that external influences are. In other words, what's the community profile? What are those reasons why physicians want to come and stay in a community? What are those connections and so forth? So not only just the opportunity analysis, but also the profile analysis. In other words, who is that? What are those pieces of that candidate that are going to be those things that are going to help them be retained? So that assessment is really, again, one that can be done with a small task force of physicians and leadership to be able to say, ready, set, go. This is the preview to planning. So know your limits, of course, and what you can do and what you can't do in terms of whether you're a 501c3 or whether you are a hospital that's recruiting, whether you're a medical group that needs a staffing plan, but what is the community demand for you to grow? And then prioritize your needs in a formal plan. That then becomes those pieces of an action plan under your formal plan. It's different from when you just said, well, we want to recruit an orthopedic surgeon because we want to do more cases. This is really a fully developed, formalized, in advance action plan to say what are the steps to be able to meet that goal. And then implement and continually assess changes in progress. And this is why we did a demand tool, which is different from a CNA or a medical staff plan. This is more interactive. The client, the hospital, the medical group then manages that themselves in those interim years. So they can document departures and new physicians that have come online, and it automatically updates their need going forward, which is going back to that scenario of the case where I was able to be invited as a speaker in the case. It was really that continual assessment of the changes over the years that made a difference. So by having the ability in-house to be able to manage that rather than only wait every 3 to 5 years to do your plan has been a huge difference in the availability of information and the accuracy of the information. So if I leave something with you at all, it would be to document, 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 and whether you're a hospital or a medical group or you're a recruiter, and to certainly involve the physicians in that planning process. Now what we'd kind of like to do is spend a few minutes, I see we have some questions that have come in, and in terms of, I'd be glad to answer any of those questions. I see there's quite a few. I also wanted to let you know that over the years we've been able to get the OIG's approved checklist, and those pieces that they utilize to be able to see if, in fact, a hospital that's recruiting has spent money, has met the obligation for the pieces. So I'll be more than happy to, if you want to send me and your email, or I think we have your emails. If you would like one, I'll be glad to send you a copy of the checklist for community need documentation. So now it's time for our QA, and I have some questions going forward. I'd encourage you to go ahead and add any that you may have in the box that's available to you on the dashboard. But in the meantime, we have some that have come in already. If we employ, here's the question, if we employ physicians, why do we need to document a community need? So again, two reasons. Number one, prior to employing the physician, the entity is generally conducting recruitment activities, such as the candidate site visits, paying for their flights, dinners, meeting the other doctors, and so forth. So these are reimbursed to the candidate, of course, and these could be future determined to be recruiting activities, and therefore a financial arrangement between the hospital and the physician. So again, document, document, document. Well, there was a need to bring that doctor in anyway, and here's our documentation around that. Sometimes, that physician may be employed with a group, and so the hospital has a portion of obligation, or it's an income guarantee, or it's the hospital employing. It's still a workforce analysis, and therefore the end game is that the physician can be successful because there was a need for him in the community. Another question that's come in is how do you define an objective analysis? Objective party or an independent party, not part of the planning process conducting the analysis, is how I would describe objective party. In speaking with the regulator, they felt that that was the definition that they would use rather than doing it yourself. Sort of the competitive environment, the more competitive it is, the more litigious it can become. And let me back up just a moment, because how do you get scrutiny from the regulators, who, of course, their goal is, certainly to look at being able to get those dollars. But how do you know that you're going to be scrutinized? And it's not generally in any kind of surveys, or it usually comes from within a competitive environment where a physician is disgruntled. And it's very easy. They're provided an 800 number, and an investigation is started. So, that's again why you want to be able to communicate with physicians, involve them into the planning process, so that they're scientists, they understand the numbers and the compelling reasons to go forward, to plan, and to grow. But secondly, it's important that they understand, that you're fully in compliance. Another question that came in is, it says, I see you don't include hospital-based specialties, and why is that? Well, many of the hospital-based specialties are workload-based, as I said, in that they can be recruited beyond community need. It's basic workload or caseload, and many of those are contracted groups, and they have a responsibility to recruit them themselves. But again, that we can also do hospital-based specialties, anesthesia, hospitalists, radiology, pathology, so forth. We can certainly do those. There are some statistics around population need, but it's a good thing to balance both that with workload analysis as well when you're recruiting. Another interesting question came in. What do you do with specialties like orthopedics when they are subspecializing? And is it in that scenario, and we do this a lot, it is possible to split the specialty into subspecialties like hand and sports and upper extremity and lower extremity and so forth, so that you get a realistic need of whether you need a general orthopod or whether you need a hand specialist. I mean, we can certainly do that as well. How do you get the information on access from the various practices that are non-affiliated in our area? Well, it's really simple. We ask. It's indicative of consumer experience, really, when attempting to establish care with a provider, and someone moves into your community and they look for a doctor. And a couple of really interesting facts is the older population that are moving into a new community, perhaps retiring, they're more willing to wait longer, where the younger families moving in, they don't connect with a physician as quickly generally, but then when they do, they want to be seen next day, same week. So we spend a lot of time, 100% of your area practices, looking for those non-urgent next available appointments, the new patient wait time, whether they are open, closed, limited to Medicare or Medicaid, and then we look at that by the median, the minimum, and the maximum wait times so that you can see across the board what that true access to care looks like. And of course, that changes as physicians open and close their practices or are more willing to take more than one new Medicare patient a month or maybe two, or they're closed to new Medicaid. And of course, the Stark rule talks about new patient access. There's one more here that just came in. So it appears that the CNA is usually completed first and then is used to develop the medical staff development plan. Is that right? Yes. Yes. You can keep them separate. There's a good reason to keep them separate. The first reason is that the CNA is really driven by both statistical and then that access to care pieces, and it gives you a full picture of what your service area looks like and feels like in terms of being a participant. But the second reason really is that by conducting a proactive analysis of the inventory, your future needs are also dependent on whether you're affiliating, whether the competitive analysis can be brought in, and keeping that separate from the Stark regulation pieces is really important. So that's why they're really two separate products. The CNA has your recommendations as a view of a strategic plan or a recruitment plan, but the medical staff development plan obviously is that opportunity to bring in more strategic initiatives around affiliation and consolidation or network development and competitive analysis. So we have completed the presentation today and questions and answers. We certainly appreciate your time. I am available anytime. Just email me or give me a call. You know, from, as I said, border to border, I can tell you that this is a very important way to approach physician development in your institution, whether you're a medical group or hospital, and I encourage you to document your thought process as you go forward to do that. Again, you're welcome to email me, and I'll be glad to send you what we believe is a documentation for community need checklist that the OIG uses to see that if you're in compliance or not. It's pretty simple, but we're more than happy to provide that for you. So I want to thank you for attending today, and let us know if we can help.
Thank you, Sandy, for that great presentation. And if you do have additional questions, please feel free to reach out to Sandy directly. Again, these slides will be emailed to you later today or tomorrow. Thank you again for joining us. Have a wonderful day.